if we're ever going to beat the disease. So now let's beat the disease if we can. We knew in the 1990s, this is a 1991 BMJ paper, that even within a normal range of cholesterol levels, this is from China, during a period of time during the Great Leap Forward when everybody leapt backward and when everybody was starving. And, you know, the top quartile of total cholesterol was like 178. And the bottom quartile was even lower. So these are people who have, by our standards, pretty low cholesterol levels. They didn't have HDL and LDL, but they had total. But what's interesting about it is that the bottom quartile had a lot less coronary heart disease than the top quartile, even though everybody was within the range we call normal. And so it looked like lower was better. And so we set out to find out if we could better understand this. And we organized the first randomized controlled trial of therapies designed to slow the disease using IVUS as an endpoint. We enrolled 634 patients. This was a trial run by C5, some time ago at 34 centers. We did the IVUS pullback. We randomized them to moderate LDL lowering with a very good statin, pravastatin, and a dose of 40 milligrams. And at the time we started this study around 1998, there had just been introduced this new, gorilla statin, atorvastatin, a very powerful LDL lowering therapy. And so the other half of the patients we just gave top doses of a very potent statin to. We then followed these patients for 18 months and did another IVUS. Baseline, 2 different therapies, and repeat IVUS. And the question was, they all got dietary counseling to the extent, we didn't do it the way...
What they did, or did they do any physical activity, meditation?
We didn't do any of those things. This was purely a drug study at the time. Again, but they did get it counseled in the American Heart Association diet for whatever that's worth. That's not all that great. I'm not sure they followed it. It wasn't, I must tell you, it wasn't intensive part of the protocol. Okay. So then in the core laboratory, I got a wonderful group of technicians there, some of whom have been there for all along through the entire development of the technology. And what they do is these are very, very meticulous people who trace the external elastic membrane, they trace the location of the lumen, and they calculate from that the gold area, which is the plaque area. And they do that slice by slice in the coronary. It takes 1 full person day to analyze 1 patient because it's very time consuming. The reason it's time consuming is that you have to look at a lot of slices. So we do a motorized pullback. So the catheter is withdrawn from the coronary at a precise rate, and then we get a series of slices spaced exactly 1 millimeter apart. If you add up the plaque in all of those slices, what you end up with is the total volume of plaque in the coronaries. Unlike an angiogram, which just measures a stenosis or 2, we get the totality of the burden of atherosclerosis in an individual patient, and that's a very precise number when done carefully. Let me show you how much disease these patients can carry. So I'm going to show you a typical, not very typical pullback. And what I'm going to show you in the pullback is a running summation of the amount of plaque in the coronary. So watch it. So there's 50 cubic millimeters, there's 100 cubic millimeters, each slice adding to the cumulative total. There's not any stenoses here, a few lumpy bumpies. There's 250 cubic millimeters, there's 300 cubic millimeters. By the time you get back to the proximal vessel, there's over 400 cubic millimeters of this nasty stuff in the coronaries. That's very typical. That's what we're up against when we treat this disease, is an astonishingly high burden. And that's despite the fact this patient has nary a stenosis in the coronary artery, but there's 400 cubic millimeters of plaque. So what happened in reversal trial? This was known as a reversal trial, published in JAMA in 2004. presented in the fall in November of 2003 at the American Heart Association meeting. And we got the LDL down to 110 in the people treated with a moderate statin dose. Now, you got to understand at the time, we had adversaries. You know, whenever in medicine you do something, there are naysayers. And the biggest ones were the people at the Brigham. You know, Gene Brunwald, one of the most famous cardiologists in the world, and that group, they said you should never lower LDL cholesterol below 125 because all you'll do is cause harm. And so they were all over the planet telling people that this study was nuts, that they knew there was no benefit in lowering LDL below 125. But we got the group to 110 with pravastatin, and we got them all the way down to 79 with atorvastatin. That's only a difference of about 30 milligrams per deciliter in LDL. It's a modest difference. Remember that up until then, all the trials with statins had been placebo-controlled. They hadn't been active controlled trials, so this was a very big departure. Not much happened with HDL. And here's the end result. The group that got moderate LDL lowering had statistically unequivocal progression. P equals 0.001. Their plaques were getting bigger. The group we got to 79 essentially gets to zero progression. It's not regression, even though it goes a little below zero. It's not statistically below zero. The p-value for change from baseline is 0.98, and the between groups p-value is 0.02. What we said at the time is that treating to an LDL of 79 halted the progression of atherosclerosis, whereas treating to an LDL of 110 did not. We got a lot of pushback, particularly from the company that makes pravastatin, some of it very nasty. We stuck to our guns and we waited it out, and sure enough, within a few months, a head-to-head trial known as Prove It was published that compared exactly the same two drugs and showed not only was there a difference in the rate of progression, but there was a difference in morbidity and mortality. Now the question was, next, what was the driver? Why did more intensive statin therapy reduce progression? Well, most people said that's a no-brainer. It's the LDL, stupid, right? Must be the LDL. And so we looked at that. And this is a type of plot that takes all of the data and crunches it down into a regression, sort of a regression line. And here's what you see, is the more you lowered LDL, the less progression there was over a very, very broad range with reasonable confidence limits. So lower was better for LDL in this trial, regardless of which agent you got. Lower was better. But then we got a really big surprise. When we teased apart the data for the two different drugs, the results weren't the same. So that the same degree of LDL reduction, some people on pravastatin get big reductions. But if you got a big reduction with pravastatin, you didn't reduce progression as much as you did if you got the same degree of reduction with atorvastatin. We were really puzzled by this. We always said, look, it's the LDL. You know, it doesn't matter what drug you use to get there. Why should it matter? And our interpretation of the data was that there was something else going on that we didn't understand. And so we looked for other correlates that might explain the greater reduction in the more intensive arm. And we didn't have to look very far till we found this. That in the intensive, the atorvastatin arm, there was a big reduction in C-reactive protein, and there was almost no reduction in the people that got pravastatin. And we then did a low S plot comparing CRP reduction adjusted for LDL level to progression rate. And guess what? The more you reduce CRP, the more you reduce progression, just like LDL. And even more interesting is that the two effects of the statin drugs were independent. There is no correlation between the change of LDL and the change in CRP in either group. And so our conclusion was that statins work by more than one mechanism. They work as LDL-lowering drugs, and they work as CRP-lowering drugs, and that these two independent effects contribute to the reduction in disease progression. It was actually a little bit humorous because the original manuscript was published in JAMA, which is a very, very good journal, but the secondary manuscript, the one that was the data mining manuscript, ended up in the New England Journal of Medicine, which is even a higher impact factor journal, and the reason is it was a novel observation that I think has held up very well over the years. Well, we've always known that this disease involved more than LDL. And we had the opportunity about the same time we did the reversal trial to do yet another study that shed a lot of light on another process. As you know, HDL we believe to be important, although the data is not as solid, and that the primary protein associated with HDL is ApoA1. That we believe HDL works by initiating reverse cholesterol transport and actually removing atherosclerotic material from the coronary arteries. Now, there's this kind of bizarre story of these 40 people in the Italian village of Limone Solgarda. I'd like to visit it one of these days. I've seen pictures. It's a cute little village in the Italian Alps. And these people have a mutated form of ApoA1 known as ApoA1 Milano that is only known to exist in 40 people in the world, all of whom are descendants of the same Italian soldier who lived in 1790. And soldiers being very good at procreation. He had a lot of offspring, and these are some of those offspring. The carriers of this protein have a mean HDL level of 17, but they have no atherosclerosis. They have normal longevity. In fact, I got to see slides of an autopsy. I saw an autopsy of one of these people who was a carrier who was, I think, 103 years of age, and whose coronaries were clean as a whistle, which was pretty impressive. A small company was able to take this HDL, this ApoA1, and make a synthetic HDL out of it. And they brought it to us in about the year 2000 and said, we'd like you to organize a clinical trial to find out whether if we can infuse this in people, we can make this super HDL suck up their plaques and regress their coronary disease. However, we had a problem. It's cost us $10 million to make enough drug for 50 patients, and we're not going to make any more. No, nobody's going to invest in this unless it works. And so we had to do this study in about 50 people. There were some animal studies that suggested that it could rapidly regress coronary disease, but we leaped a few steps and took this into man with the blessing of the FDA and the IRB, and a study that was done in the first few years of the last decade. We actually ended up with 47 patients, some of whom got placebo, some of whom got a low, and some of whom got a high dose of this synthetic HDL, but we only treated them for 5 weeks. Now, the reversal trial was an 18-month trial. We gave them 5 infusions of this synthetic HDL